the toxicity associated with the CAR T is severe, and its management has always been one of the critical issues in the CAR T cell therapy. So those days we have learned much about how to manage the toxicities. So there are, in my opinion, there are 4 categories of CAR T cell related toxicities, including CRS and neurotoxicity, infection related toxicities, and others. So others including hematological and non-hematological. For example, non-hematological including hypotension, hypoxia, and hypophosphatemia. So in all these categories of toxicity management, we have gained significant progress. So let's focus on CRS. CRS initially was a very scary thing with people with high fever, shaking, and with hypotension resulting in the hypoxia, and somebody have to be transferred to ICU with put on pressors to. And initially we were shy about using steroids, and we are shy about, we do not have enough tools to manage it. So the management of CRS, including antibiotic therapy for neutropenic fever, hydration for hypotension, providing oxygen support for treat hypoxemia. I have used IL-6 receptor antagonist tocilizumab, and also the ligand inhibitor of IL-6 ligand using cetuximab. We are also using the much more sophisticated means to treat CRS. We have used the ATG. We have used other means. So we were able to recognize the CRS early and intervene early. So this all helps CRS used to be a very severe challenge in the toxicity management because frequently it may lead to death in clinical trials. But nowadays we hardly never lose any patient to CRS in the management of lymphoma therapy with the CAR T cells. So on the neurotoxicity management, we have also gained much knowledge. Number one, we recognize its pattern already. We intervene early. We are much more efficient with the steroids usage and its timing, its dosage. And we are using tocilizumab and other like ATG, and we are using neurological support with a mannitol if needed, and sometimes we even use extreme measures to inject RC and steroids into the cerebral spinal fluid. Of course, this has never been tested in the clinical trial. You should only use this strategic with caution. And I have personally also used ventriculostomy when there's a significant MR evidence for cerebral edema. The intracranial pressure is very high. To avoid herniation of the brain, we use the ventriculostomy to let the pressure go. So our knowledge on how to manage seizures has also grown. So basically, overall, we are much more efficient and effective in controlling neurotoxicity. The next challenging issue is the infections. Infection may happen during the CAR T cell, right after CAR T cell infusion, or after the patient has been in remission for a long time. We can still lose the patient to infection. So we have to realize that our population has been treated about 3 times using the median 3 prior lines of therapy, and they have already received many rituximab chemotherapy, and they are severely immunocompromised, not only by lymphoma, but also by past therapies, especially chemotherapy and rituximab, which is known to delete B cells and cause hypoglobulinemia, which is a significant factor in underlying infectious disease risks. So we have, in the long run, even after the lymphoma is in remission, we have severe B cell depletion, not only caused by the past chemotherapies, rituximab, but by CD19 CAR T cell, which further cause profound B cell aplasia, called B cell aplasia. So this eventually leads to severely compromised immunity, our ability to fight infection is very profoundly compromised, therefore leading to not only regular bacterial infections, viral infection, but also opportunistic infections such as fungal infections, with all kinds of infections reported, at least including cryptococcus fungal infection and histoplasmosis infection, and to name just a few. So, so we have been using early antibiotic therapy, trying to wipe out the early infections such as sinusitis early, and you treated the early, prevented it becoming a pneumonia. And we also have frequently using IVIG to replace the hypogammaglobulinemia. So those factors and the others has significantly decreased the infection rate. And also, we are in the COVID-19 time, and the COVID-19 complicated with the CAR T cell post-course is also could be detrimental to the patient. But with so much vaccines now, and we recognize of the complications of COVID-19, we have been extremely careful in handling this patient who received prior CAR T cell therapy.